Mario is going to be talking about COVID-19, Dogma, Hubris, and the forgotten lessons of SARS-1. He was prominent in the original SARS Commission. After the outbreak in Canada from 2003 to 2007, he served as a senior advisor to Mr. Justice Archie Campbell, who led the SARS Commission in Ontario following the outbreak of SARS-1. And this was a result of Canada being the most affected jurisdiction outside of Asia. His focus was on pandemic planning and the occupational health and safety issues. And he's authored 2 reports on COVID-19, one, A Time of Fear, and another, Fatal Choices. He's also testified on the response to the pandemic before the Canadian House of Commons Committee and the Morocco Inquiry. And he's a frequent leader on Canadian television and other media. In fact, he's one of the most recognized people, I think, with response on COVID that I know in Canada. So it was a great pleasure to welcome Mario and his talk. Thank you. Please go ahead. Thanks.
Hi, good morning, good afternoon, and good evening. And Simon, thank you very much for the kind introduction. I'm delighted, honored to be here, and my presentation today will be in 2 parts. The first part, I will go over the lessons of SARS-1, what we learned from it, and the second part will look at what happened subsequent to SARS-1 in the 17 years between that public health crisis and the advent of COVID-19. And do that through the lens of the lessons of SARS, which I believe were largely forgotten. Next slide, please. I'm sure that all of you have seen this very famous quote from George Santayana, and I think it'd be hard to argue with him that if we fail to learn from history, from our past mistakes, we're doomed to repeat them. And I think, one of the really troubling aspects of the COVID-19 response is that, in my view, we did not learn from the past. And I think one of the challenges of COVID-19 will be, will we be able, as a society, as humanity, to learn the lessons of COVID-19? Next slide, please. One of the ways that our species has been able to further itself all the way back to the beginning was by the collective memory of disasters. And there was an interesting study done in Czech Republic looking at data going back to the 1200s with respect to flooding in the Vltava River. And floods were relatively infrequent, but devastating. And what the study found was that within about 2 generations, people forgot about those floods and began building on the floodplains. And so the question is, what are the limits of our collective memory? How can we ensure that our collective memory is sound and more robust? The Czech study said 2 generations, but it's been 17 years between SARS and COVID-19. And so perhaps, in an age of social media, our collective memory is shorter, and thus the challenge of ensuring that we learn from the past. Next slide, please. I want to give you a quick recap about SARS-1. It featured a coronavirus pathogen, and until then, coronaviruses had not been regarded as possible agents for a pandemic. There were a lot of very diligent coronavirus researchers who've been laboring away in the shadows, who were vindicated in some ways that the coronavirus had this ability to become a pandemic agent. So the timeline of SARS-1 was eerily similar to COVID-19. First cases were roughly November 2002 in China. It appears that the virus came from a wildlife reservoir. In the end, SARS affected about 8,000 people, killed 774. These are estimates because we did not have a reliable test at the time to confirm whether someone had SARS. So this is all based on the clinical analysis, and so it's an estimate. So Canada, China, Hong Kong, and Taiwan had most of the cases worldwide. Toronto had the largest outbreak outside Asia. So, it wasn't really Canada, it was Toronto that was the outbreak. One of the positives in Toronto was that about 30,000 people were in voluntary quarantine. But there were also signs in studies looking at the voluntary quarantine issue that echoed what has happened during COVID, that there's a limit to what people will voluntarily do for the public good and the public health crisis. And again, a lesson that perhaps we should have kept in mind. Next slide, please. The SARS Commission was appointed in June of 2003, and it was led by the late Justice Archie Campbell, my good friend and mentor. It was structured like a transportation accident investigation. Justice Campbell could make no findings of criminal or civil responsibility. And full disclosure and prevention of future accidents required trading of anonymity for candor. So while there were some public hearings, most of the fact gathering was done in camera. Justice Campbell released his final report in early 2007, and sadly he passed away. He passed away in April of 2007. That's a mistake on my part. One thing I want to let you know that isn't well known is that Justice Campbell was very, very ill in the last year of his life. He would come into the office with an oxygen tank, and he continued to labor despite being in very, very poor health, because he hoped that the lessons of SARS could help prevent or mitigate, rather, a future pandemic. Next slide, please. A key finding of Justice Campbell arose from the comparison between Toronto and Vancouver. So as I said, Toronto had the outbreak, Vancouver did not. Interesting as a comparison, the index patients, and there were 2 index patients in Canada, the 2 index patients presented to hospitals, one in Toronto, one in Vancouver, within hours of each other on the same day. Vancouver General treated the index patient on a precautionary basis. Staff wore N95s. It was isolated very, very quickly, and the outbreak was contained. The Toronto index patient was left in a hallway for 19 hours. There was no concern about the possibility of airborne transmission, and that led to the huge outbreak in Toronto. Next slide, please. Vancouver General really impressed Justice Campbell because they followed the precautionary principle. And one of the top infectious disease people told the commission, we're heretics, and they never use droplet precautions. And their view was they start with the highest level of precautions, and then as the clinical situation becomes clearer, they step down those precautions if that was warranted. And that really impressed Justice Campbell, and it demonstrated, in his view, that this led to Vancouver General stopping the outbreak before it could get underway. The other part about Vancouver General that really impressed Justice Campbell was that it had a really good collaborative environment. In so many hospitals in Canada, the infectious disease people really are not collaborative. But in Vancouver General, they were. Uh, uh, for example, on their daily rounds, infectious disease physicians were teamed with occupational health and safety people, so that there was collaboration on the ground between infectious disease and occupational health and safety. And one point that they made, these are the experts at Vancouver General, was that they listened. They listened to staff, they listened to nurses, and they really paid attention to what they said. And listening is such an important aspect of it. And it was in real contrast to what happened in Toronto. SARS-1 was in two waves. The first wave ended roughly around April of 2003. Toronto celebrated. There were full-page ads and events to mark the end of it. But at one of the local hospitals, a hospital called North York General, nurses there didn't think it had gone away. They kept seeing patients that had the symptoms of SARS, and they felt that it was too early to pull the plug and declare victory. And things became very heated. There was a meeting between the infectious disease people and the hospital leadership and the nurses. And the nurses kept giving all this evidence that SARS had not gone away. And, they were really browbeaten and bullied by the staff. Basically they were told, read my lips, SARS is gone. In fact, it hadn't. And within days, there was a huge second outbreak, more deaths at North York General. And the lesson there that Justice Campbell took from it was that the importance of listening to frontline staff and not being guided by dogma. Next slide, please. So the lessons that Justice Campbell took from the experience of Vancouver General, in contrast to Toronto, was the importance of taking a precautionary approach. It's a precautionary principle. And, as he wrote very eloquently, we should be driven by the precautionary principle that reasonable steps to reduce risk should not await scientific certainty. Next slide, please. In Toronto, the leadership of the SARS response was really an ad hoc committee. There was no public health agency. And in late March, the leaders became very concerned about the possibility of airborne transmission, and they mandated the use of N95 respirators. They did so without really consulting the infectious disease community, and that community was really upset, and I can tell you quite livid that this had been done. Now, in going to N95 respirators, the committee had the right idea, but the execution was problematic. There was no fit testing. In most cases, staff arrived to start their shift at a hospital, and they found these boxes of N95s, and they were told to put them on. So it was a real mess, and there are all kinds of cases where people put surgical masks underneath N95s, and you all know what the issues are there. And throughout the pandemic, the leading lights of the infectious disease community in Toronto really argued against the N95, said it was nonsense, and this was a droplet disease, and on and on. And it wasn't until 1 year after SARS that the first evidence, a brilliant study by Hugo Lee in Hong Kong, demonstrated that SARS was an airborne disease. And this led Justice Campbell to write that study and others pointed to the possibility of airborne transmission, not just of SARS, but also influenza, suggested the wisdom and prudence of taking a precautionary approach. Next slide, please. The other aspect that Justice Campbell raised was that we must be prepared for the unseen. We must be prepared for a new pathogen for pathogens that act in a wholly new way. And that message was echoed by the WHO in 2018 when they warned about disease X, that we just can't be closed-minded and believe that all pandemics will be caused by influenza. It is just not that simple. Next slide, please. Sadly, those lessons, those recommendations from Justice Campbell and WHO were really not followed. In Canada, as Dr. New admitted in 2020, we prepared for an influenza pandemic, and our response was based on influenza pandemic planning, not for the new. In the UK, as Dr. Horton wrote in The Lancet, or rather in The Guardian, the same thing. The UK imagined that the pandemic would be like an influenza pandemic. There were many comments and suggestions that influenza could be used as the marker, as a proxy, if you will, for COVID-19. And one of the studies that was used was to support that was a very controversial study done in 2016 that suggested that against influenza, an N95 is no more protective than the surgical mask. This was a controversial study, but it was touted significantly in the start of the pandemic as justification for sticking with the large droplet theory and using large droplet precautions. Next slide, please. One of the things that SARS-1 really ushered in was a golden era of research into aerosols and respiratory pathogens. It was really kicked off by that brilliant study by Hugo Lee into SARS, its airborne transmission. And Chad Roy and Donald Milton really jumped on this in a terrific opinion piece in the New England Journal of Medicine that accompanied Hugo's study. And what Drs. Roy and Milton predicted was that we were entering a golden age of research into airborne transmission and aerosols, and they were right. The next 17 years really were full of brilliant research, and in many ways they paralleled the research into vaccine and mRNA vaccines, which allowed us to produce these brilliant vaccines so quickly after the advent of COVID-19. Next slide, please. Among the brilliant researchers was Dr. Lydia Buruaba of Canada, who's at MIT. And she published a study in 2014, really demonstrating that the large droplet theory and the 2-meter rule and all that really were not based on science and were not effective. And we should really move to adapt our public health rules and infectious disease rules based on the science of aerosols. Lydia and Don Milton and others tried at the start of the pandemic to warn public health officials, to warn the CDC, and here in Canada and WHO, that the science that they were relying on was really outdated and ineffective. But they were really ignored, and it's tragic that they were. Next slide, please. And the work that Lydia did and Don Milton and others was a long time coming, but by the dawn of the COVID-19, there was such a huge, rich body of research analysis on aerosols that it really shoved, if I can use that word, the large droplet theory away from stage, and it should have been just dumped into the dustbin of scientific history. Next slide, please. One of the things that happened in the first year of COVID-19 is that researchers were able to demonstrate COVID-19's airborne characteristics very, very quickly. And in fact, as this great slide by Dr. McDonald demonstrates, is that there's more evidence of COVID-19's airborne transmission than there is for measles, which is the classic airborne disease. And again, this is a result of all that research that allowed us to really move quickly to understand COVID-19's airborne dynamics. Next slide, please. But there was real resistance by WHO, by infectious disease experts here in Canada and the US and public health agencies to these findings. And you know, when you ask why, a big part of it was that the research, this great body of research, was not done by the infectious disease community. It was done by engineers, aerobiologists, and on. And you know, when Dr. Allegranzi made this comment, you know, she was really exasperated. She said, you know, why are you listening to these people? You should listen to us. You know, we know what's going on. But in fact, the people who had done the research were these engineers, aerosol experts that we've talked about. And the infectious disease community, by and large, did not engage in research in between SARS and COVID-19 to perfect their the large droplet theory. And equally importantly, they did not engage in a collaborative manner with the new researchers, with the Don Miltons and Lydia Marascas. They just shunned it. You know, it was a bit like China in the 14th century when it burned its ships and stopped traveling around the world, believing that history had stopped. One other point of irony is that the large droplet theory was really based on research by Dr. Wells at Harvard in the 1930s. And what he used was equipment, primitive in our eyes, but very advanced at the time, developed by engineers. And that equipment was primitive, and it was able to spot large droplets. And that's what he based his research on. But he was ironically very thankful to the engineers that created the equipment that allowed him to make his findings. And he hoped that his findings were not the end, but the beginning of research. And you know, I wish that Dr. Allegranzi and the others had perhaps gone back and looked at Dr. Wells's work and seen that in my view, in my opinion, I think he would have sided with the aerosol experts who did all that great research. Next slide, please. And one thing that Justice Campbell recommended was that he felt, and again, it's based in part on the experience in Vancouver, that the issue of pandemic and pandemic response really requires collaboration between all the relevant experts. And what he saw is that in Vancouver, that was the case, and it worked, it was effective. In Ontario, it did not. And in Ontario, infectious disease experts during SARS-1 really did not collaborate, did not want to collaborate, and did not see the need for other expertise. And it was a tragic decision that they made because it carried on into COVID-19. Next slide, please. So let's move to the dawn of COVID-19 and look at it through the lens of SARS-1 and what happened in the intervening years. So I would suggest that at the start of COVID-19, there were grounds to take a precautionary approach on whether it was an airborne disease. You know, we didn't know one way or the other, but there were clues that I think should have warned us to be cautious. First of all, was that COVID-19's cousins, SARS and MERS, both had airborne characteristics. Secondly, there was all that research that Don Milton's and Hugo Lees had done between SARS-1 and COVID-19 that really showed that airborne disease was really a far more complex and far more nuanced issue than the large droplet theory its proponents would have suggested. And the third piece of evidence was that China had gone to airborne precautions in late January. China had seen a spike in infections amongst healthcare workers in the first part of the pandemic in January of 2020, and they'd gone to airborne precautions, and infections of healthcare workers dropped almost to nothing. So there was really good evidence that airborne precautions were effective against COVID-19, even though we really didn't know enough about it. Next slide, please. There was also in February and March of 2020, there was also a huge flurry of articles and papers emanating from China, warning the West that this was possibly an airborne disease, but of the need to take airborne precautions. They talked about the fact that people without symptoms were able to spread the disease, but they really made the case that we really should be careful. And I think we need to differentiate between the actions of individual scientists and doctors in China and the actions of their government, and the government, an authoritarian government that has not been as transparent as we would like on the origins of COVID-19, et cetera, et cetera. But individual doctors and scientists in China were really trying to warn us that this was an airborne disease. And I remember, in March, talking openly over the email to colleagues in China, and one sent me a video of his staff putting on airborne precautions before going into a ward to treat patients. So there was an openness and collaborative nature there, but we did not listen to all of this. Next slide, please. And while this was going on in China, with all the information that we knew, the WHO said it's not airborne, full stop. Next slide, please. In Canada, because of Justice Campbell, the precautionary principle was embedded into Ontario's public health law. So that meant that at the beginning of the pandemic, Ontario was required under the law to follow the precautionary principle. But there was a huge backlash to that by the trauma infectious disease community, many of whom had been quite angry with SARS and with the use of N95s and SARS. So it was a continuum there, and they waged a very public campaign, talking to newspapers and saying, this is nonsense. This is not an airborne disease. I don't know where the ministry gets its advice. They cited the controversial study that N95s were as protective as surgical masks, and on and on and on. And as a result of this campaign, Public Health in Ontario ruled that it was not an airborne disease. We did not need the precautionary principle, and it was lifted. And from that point on, Ontario followed the large droplet theory to our detriment, and it is very, very tragic. Next slide, please. And throughout the spring of 2020, at the WHO and at public health agencies in Canada and the US and Australia and the UK, experts, occupational hygienists and aerosol experts were trying to persuade public health agencies that we should be cautious. Now, what they said is that it may not be conclusive that COVID-19 is airborne, but gosh, the evidence suggests that we should take a precautionary approach. But my goodness, in these closed-door discussions, there was no scientific engagement. It was really our way or the highway. It was really a profoundly disappointing to me, because I had hoped that in around the discussion table, that scientists open to science would engage in collaborative and open discussions to try to get at the truth. One of the top people who was involved in this was John Udick, a really terrific Canadian occupational hygienist. And what I have the honor of portraying in my first report, A Time of Fear, and there's a link there at the bottom of the slide, was I wanted to really capture what was being presented to public health agencies as evidence that we should be, excuse me, we should follow the precautionary principle, and that the evidence was not definitive, that we have definitive evidence rather of airborne transmission, but that there was enough evidence to be cautious and follow the precautionary principle. Next slide, please. And then in July 2020, in a letter co-written by Drs. Murawski and Milton, they basically said, and it was an attempt to reach out to the public health agencies, WHO, and to the infectious disease community. We may not agree, they suggested, we may not agree on whether there's enough evidence for airborne transmission, but gosh, let's agree there's enough evidence for us to take a precautionary approach until we can conclusively show one way or the other. Next slide, please. But this was met with disdain and not with an openness that with which it was written. The comments from the infectious disease people, including Canada, were really troubling. Calling it a tempest in a teapot, claiming that Milton Murawski were just trying to foment some controversy. And there was a real break in the dialogue, because what Drs. Milton Murawski and others were saying was that there's enough evidence to take a precautionary approach. There may not be enough evidence to suggest that it is in fact airborne. So sadly, it was a bit like the dialogue between climate deniers and the rest of us. Climate deniers keep saying, we don't have enough evidence, we don't have enough evidence. And arguably, it's ironic that one of the greatest public health successes was a success against tobacco smoking. And there for years, the tobacco companies were saying there's not enough evidence of the link between smoking and cancer. The public health agencies were taking a precautionary approach. And it's sad that they didn't carry that over to COVID-19. Next slide, please. One of the problems is that Canada, sadly, is one of the strongest places for the large droplet theory. And the rebuttal to the Murawski and Milton letter was co-written by a group of Canadian infectious disease people, and 40% of the signatories were Canadian. Next slide, please. And Dr. Justice Campbell said that or called for bringing together collaboratively between what he saw the infection control and the worker safety disciplines. And he warned that, until that divide is bridged, we're going to be in trouble. And that divide was not bridged. That divide was, in my view, part of the problem where the response to COVID-19 was so tragic and so ineffective. Next slide, please. So why the response to follow the precautionary principle? I think part of the answer is to look at the history of scientific revolutions and to Thomas Kuhn's brilliant book, and that is that whenever there's a scientific revolution, there's often people who held the old dogma and refused to change, refused to engage in the new changes. Next slide, please. One of the most famous was of course Galileo and attempts by the church to suppress him. Next slide, please. And we see the same thing happening with Dr. John Snow when in the 19th century England, when he demonstrated that cholera was spread through water, contaminated water. Next slide, please. And one of Dr. Snow's strongest antagonists was Maximum Pettenkofer. And Dr. Pettenkofer continued to his death for decades to rail against Dr. Snow and the cholera waterborne paradigm. And right to the end, he defended his views. And I think that I fear that many of the strong proponents of the large droplet theory are going to be looked at by history as Max von Pettenkofer has. Next slide, please. I think that if there's a word to sum up the large droplet community over the pandemic response and generally in public health, it's really hubris. And the opposite of hubris is humility. Next slide, please. We saw all kinds of examples of this arrogance. I remember a public health officials at the start of the pandemic just saying that there's no way that the lockdowns that were then happening only in Wuhan would come to Canada. It wouldn't come to that. Next slide, please. But I think what all this shows is the importance of humility in medicine. And Dr. Colohan is a strong proponent of this. It's important to put aside arrogance and entitlement and really be humble, especially in the face of a new pathogen. Next slide, please. One of the witnesses to the SARS Commission talked about that. And what he said is that SARS humbled us. It has made us realize that even when we think we know everything, we don't. And that was such an important lesson of SARS. Next slide, please. And Dr. Fauci himself admitted this in the fall of 2020 when he gave this terrific lecture to the Harvard Medical School. And he said that you've got to be humble. You've got to be flexible enough to change your recommendation regardless and the policies, depending on the information and data as it evolves. Next slide, please. And one of my heroes in COVID-19 is Dr. David Fisman. Dr. David Fisman was a strong proponent of the large droplet theory, but he realized that it was ineffective, and he changed his mind, and he admitted that he'd been wrong. And he's, I would hope that going forward, people look at Dr. Fisman and others and see the need to be humble and to not be afraid to say that they're wrong. Thank you very much. That ends my presentation, and thanks again for this kind invitation to appear before you.
Thank you very much, Mario. That's an absolutely excellent presentation, extremely comprehensive, and it provided so much background to recent events and perhaps explanations of the actions by those in authority. There's a lot to digest there, and I think participants are extremely appreciative. If there's okay to answer some questions, that'd be very welcome. And participants are invited to put theirs in the Q&A block in the Zoom call. So thank you very much indeed. Thanks. One question we have from Nicholas Smith is, in December 2020, you testified in front of the Ontario Long-Term Care Commission about the importance of using elastomeric respirators, and that the government was refusing to use them or to promote their use. In fact, the Ontario government has locked up 100,000 elastomeric respirators since July 2020, saying they'll only be used in future pandemics. And the Quebec government has locked up 80,000 since February 2021. Why is nothing being done to get these types of respirators to healthcare workers from the government PPE stockpiles? Thanks.
Well, Nicholas, I think that's a great question, and I'm not in a position to answer it, but I think that what it points to is the need to have commissions of inquiry in Canada and probably other countries to really delve into those issues and to really investigate why elastomerics were not used as they could have been, as they should have been, and on and on. So I think a great question, and I think we need independent commissions of inquiry like the one that Justice Campbell headed to really get to the bottom of these issues.
Thank you. Thanks so much. Another from Dr. Stella Hines, who actually contributed to our pre-conference professional development seminar. I do not understand the opposition between infectious disease specialists and occupational safety and health experts. It is real, and there is legacy dating back to at least the 90s. What do you see as strategies to promote cooperation between these two fields as opposed to adversarial?
Well, one of Justice Campbell's recommendations was that in setting up the Public Health Agency of Canada and of Ontario, it should be a collaborative situation where power and control was not only in the hands of infectious disease people. And Dr. Tricia Greenhall in Oxford has talked about this, about who controls the narrative. And the narrative is controlled by the infectious disease people. And the recommendation that to have a collaborative environment where occupational hygienists and aerosol experts would have equal standing with the infectious disease community was really dumped and ditched. And so I think we need to look at our institutions and refashion them in a way that there is this embedded institutionalized collaboration. And I think, as long as the infectious disease community controls the narrative, I think it will be hard to do that. There is a grain of hope, though, is that I've heard that younger infectious disease experts want to change course, but that the dogma of the people who control the narrative is preventing them from doing so. And I've also heard reliably that a number of younger infectious disease experts wanted to speak out, but they're really afraid for what that would mean for their careers. A sad thing, a sad case. But I think that we need commissions of inquiry and refashioning our institutions to really address this issue head on.
Thank you. Thanks so much. Actually, I had a sort of extending question to that. In that we have heard a lot from the infection control community that randomized control trials are the highest form of evidence, and proposals even from senior members of that community to test out respirator effectiveness by having some healthcare workers wear surgical masks, some wear fitted respirators to see who got infected respirators were. And this is in spite of basic observations around fit. Frankly, if there was a fire at the hospital, nobody would dream of sending half the firefighters in with breathing apparatus and half not, in order to prove that the equipment worked. So is this a case of a hammer of infection control principles and every intervention included in safety equipment being a nail? Or is it has even been said this is sometimes perhaps a gender issue, that the predominantly female and male workforce that is causing this divide. But I wondered what your views were on that and what could be done for the future.
That's a great observation and a great question. Thank you for that. I think part of the problem is that the infectious disease community latched on to a misunderstanding of evidence-based medicine. So evidence-based medicine, which required randomized controlled trials, was really intended to ensure the safety of vaccines, of new medicines, of new surgical procedures, where you want to have a huge level of certainty before these medicines and procedures are accepted. With respect to issues like protecting the public, you cannot wait until you have absolute certainty. We saw that with climate change, and to this day, there are people who say we don't have enough evidence to act to stop climate change. As I indicated earlier, the tobacco companies made the same arguments when public health was gearing up its campaign to curb smoking. And I think we have to redifferentiate what areas of science and medicine it's appropriate to have the level of certainty in randomized control trials, and where we need to take a precautionary approach. And I hope that goes forward as well.
Thank you. Thanks so much. Two more questions, if that's okay. I will mention, you mentioned Trish Greenhalgh. She's actually speaking at this conference tomorrow. We have her later in the day.
Yeah, she's terrific. She's excellent. I urge everyone to attend that.
Thanks so much. Dorothy Wigmore asks, where do we go from here, Ario?
Yeah, I mean that's a fair question. That was asked by a famous Russian writer. His name escapes me, in the 19th century. What is to be done when Russia was in a quagmire? I think one is that we need commissions of inquiry. We need to make sure they're independent. We need to make sure that the infectious disease dogma does not put its finger on the scale. That's really important. But I think we need to continue what I believe attendees and Simon, you've done, and others, and Dorothy Wigmore, to really continue to argue in favor of science. It continue to really demonstrate that we need to follow the science and to work collaboratively. And that's a sort of a mission of civil society. That's really important. But I think good commissions of inquiry, I think part of it too is we all have to be vigilant to make sure that commissions of inquiry are not geared to protecting the status quo. There's one set up recently in the province of British Columbia, which is really, a CYA exercise, if you don't mind me using that term.
Oh, thank you.
Sorry, just one last point is that I think the infectious disease community needs to learn from engineering, and engineers are really base their work on the precautionary principle. And as one colleague said to me, it's why we don't see planes falling out of the sky or bridges and buildings collapsing on an ongoing basis. And there's also an accountability and transparency in engineering that we don't have in infectious disease. So I think I would urge that community to learn from engineers. I think they have trouble learning and believing that others have expertise. That's really vital.
Right. Thank you. Thanks so much. Another question from an anonymous attendee. He gets around a lot, that guy. Are you or others studying the market failure as to high quality reusable face coverings for use by the general public? And that's not healthcare or other occupations, with institutions that can invest in their employees.
I don't have any expertise there, any knowledge. A great question. I look forward to perhaps others can answer.
Thank you. Okay. And Stella Hines again asks, did the Vancouver hospitals, it's an interesting one, have similarly favorable outcomes with COVID-19 as they did with SARS-1? And was the precautionary principle still used?
That's a good question. And I think one of the tragedies is that British Columbia turned its back on its golden record in SARS-1. And by the dawn of COVID-19 had been turned into large droplet environment. And so British Columbia has followed the large droplet theory. Plexiglass is everywhere. There's a belief that surgical masks are good enough. The chief medical officer of health of the province refuses even to use the word airborne. Data has not been published that might support airborne transmission. It is a really sad sight. At the start of the pandemic, I thought if any place is going to do well, it's British Columbia. But in fact, British Columbia turned its back on a legacy that had really been a golden standard for pandemic response. And recently the governor of BC formed a 3-person commission inquiry into it. But it was done by it's comprised of ex-bureaucrats, and I think it'll be a CYA exercise, I'm afraid.
Thank you. Thanks so much. Still invite people to submit questions. Another one I had was we saw perhaps a wider issue in the shifting responsibility for selection of PPE. And in Ontario, we had the situation of the point of care risk assessment, whereby healthcare providers, healthcare workers had to undertake an immediate assessment in the environment they were in or entering into to determine the protection that they needed. The onus was on them rather than on their employer. This would be unthinkable for a worker in a chemical plant or in a smelter. And yet this is against a potentially fatal disease. And how do we overcome this alarming division?
Yeah, that was just a tragic situation. And in my second report, we documented case after case after case where in long-term care facilities, nurses raised the issue of airborne transmission, asked for N95s, but they were bullied by infectious disease people who were seconded from hospitals to long-term care facilities. They were bullied and they were shamed in front of their colleagues by people who said, read my lips, it's not airborne. So I think, putting the responsibility of individuals when all the odds are against them, when the institution is there in their face, writing emails saying that concerns about airborne transmission are baseless. I think it's really foolish. I remember, at one major Canadian hospital, the head of infection disease is a major figure in the community, and he talked to reporters and was quite proud that he'd calmed down some nurses who were concerned about airborne transmission. It was so patronizing and so went so against human values, but also against the importance of listening to people. The importance that was shown at Vancouver General, that was shown to Vancouver General, that you have to listen to people and be open-minded. When in fact all that this infectious disease figure wanted to do was shut them up and calm them. I mean, it was just appalling. And he's still there. No consequences.
Well, thank you very much again for absolutely excellent presentation, and would invite you to join the rest of our conference as well. I think we have some more discussion on the pandemic tomorrow, so that will be good. Once again, it's been great having you. Thanks again to participants and to those who posed questions. Oh, we have one more question, so if we're okay, a couple of minutes. Dorothy Wigmore asks, she's heard several public health policy people dismiss the precautionary principle, and she knows it's been interpreted in several ways. How would you respond to those who are wary of using it, and what's the best way to present it to the public these days? Thanks.
Well, the precautionary principle is how most of us lead our lives. It's what we teach our kids. In life with unknown risks, being cautious makes sense. especially when you have good grounds for being cautious. And I think that the analogy to climate change is an important one. I think most people now get it, that with climate change, we cannot wait for certainty. We have to act. If we don't act, if we wait for certainty, it will be too late for us and for future generations. But I think that that's an important one. But also, when you look at engineering, I think the engineering model is one that needs to be used more and more to demonstrate the importance of the precautionary principle. And people need to understand, why are planes safe? Why are bridges safe? Why are buildings safe? Well, it's because engineering is really based on the precautionary principle. And also, this is really significant, that engineers are accountable for their actions and for any failure to ensure safety. And we've all seen, trials where engineers are charged with not being with being negligent with respect to their responsibilities. There's none of that with infectious disease, with public health. And I think we need accountability, and we need transparency. In my presentation, I talk about what went on behind closed doors when people like Don Milton, Alita Maraska, and John Udick were presenting compelling cases, in my opinion, about the need to take a precautionary approach. The people who said no did so behind closed doors. Transcripts were never published of those discussions, and they've never been held accountable. They will go on and retire with nice pensions, and they will never be held accountable, and they need to be held accountable.
Oh. Thank you. Thank you very much again for a great presentation and a great discussion afterwards. Apologies everyone for going on slightly long, but I think it is well worth having this very informative discussion. Thank you.